Thank you very much, Jörg, and it's a real pleasure to be with you in this masterclass. Thank you, Professor Pestana, for this introduction. Probably you will show some slides in duplicate form and probably with some comment, with some interpretation, with some discrepancy. This will be very interesting for the discussion after. This is my disclosures with the presentation. So in the 15 minutes that I have, I will try to have 3 points. First of all, what have we learned by the classical lung protective ventilation in ARDS hypoxemic patients? So the rationale as we showed previously, but in another way. Secondly, what are the most recent clinical evidences which modified the factor associated with mortality that we can change, especially as you see the pH, the PCO2, the plateau pressure, etc., as we demonstrated. And then finally, what are the clinical evidence to apply the extracorporeal CO2 removal in ARDS patient or in hypoxemic patient or in hypercapnic patient? We will see, and I will probably focus more in some physiological data as we see that there is no, even there are no strong evidences, there are several physiological studies showing benefit in terms of respiratory variables. First of all, this is a normal lung and this is an ARDS lung. Our objective is to avoid the transformation between normal to ARDS. This is a preventive. I believe that preventive cure is probably one of the best now. Even we used everything, mainly the lung protective ventilation, and to avoid worsening of an ARDS mild to moderate to severe. This is the introduction. The main objective of the ventilation is to ensure gas exchange. First of all, oxygenation to maintain a PO2 between 17 and 19. And secondly, is to maintain a normal PCO2 between 35 and 50. First of all, primum non nocere, this is the main. During 13 years, we treated the RDS by just to maintain physiological variables in the normal range. And we learned in the 2000 that probably we should take in count more than pressure than the variable physiological of arterial blood gases. So how to ensure gas exchange is to have a minute ventilation. As you know, the tidal volume multiplied by the respiratory rate. So to avoid the acidosis hypercapnia, we should increase the minute ventilation by increasing the volume and then leading to increased pressure, leading to the ventilatory induced lung injury, the VD. So to avoid this, we should decrease the volume and decrease the pressure. When decreasing the volume and decreasing the pressure, you have alveolar hypoventilation, then you have the price to pay is a CO2 accumulation. That means is hypercapnia acidosis. Then the concept of hypermissive hypercapnia was developed in the 1975 and the 80 with the initially with the asthma patient and after in ARDS patient, and then the acidosis hypercapnia. Now we should limit it. So what we can do, the lung protective ventilation, as you know, is the association of low tidal volume or limited tidal volume with high PEEP to avoid the alveolar derecruitment. This slide shows what happened during the 15 last year since the start of the RDS. As you see, during the 16 and 18, we have a low PEEP and a high tidal volume between 12 to 15, as you can see here. And then during 19, we decrease the tidal volume, increase the PEEP, and then we, in 2000, we have the most known paper of ARMA showing that low tidal volume is protective, or maybe high tidal volume is worsened. We don't know really what is the reality today, but we know that probably it's better to avoid high tidal volume. So after, as you see, in the most recent 10 years, we have high PEEP for the most severe patients and low tidal PEEP, low tidal volume. So now what could be the future? The future, the question is how we can apply ultra-protective ventilation and then to help to use ultra-protective ventilation by decrease more and more the tidal volume and decrease more and more the airway pressure. Then we have to CO2 removal to do, and maybe we can use ECCO. So The slide is from the paper from Alain Combe and Arthur Sletsky in the JAMA in 2019. You see that the objective is to minimize the hypercapnia and minimize the lung stress and strain by using ECCO, for example. This is a paper that we performed with Professor Alain Combe, that we summarize the patients that can be potential indication. We can discuss effectively the acute hypercapnia patient with respiratory failure, like the COPD patient with acidosis. This patient could be benefit. We have now some studies showing benefit in terms of physiological variables, mainly respiratory variables. Acute hypoxemic patient with respiratory failure in ARDS. This is a question we have a lot of papers on physiological studies showing benefit, but in terms of randomized control trial, we have two, that the two studies are negative in terms of mortality, but there are some signals that could be helpful and better identify the patients that could be candidate to benefit. And the other indication, as you see, you have the asthma with hypercapnia, and we have the bridge to lung transplantations. This is the same slide, but showing that the indication, the bridge to lung transplantation, the moderate ARDS may be helpful in some cases individually, and the COPD patients and asthma, status asthmatics. So at the question, what could be the ideal timing of therapy initiation? My answer that we have really few data to answer of this, because there is no study comparing early versus late initiation. In my point of view, in terms of physiological point of view, as said Professor Pestana just before, probably is as soon as possible, very early, and in the most studies on the two recent randomized control trial, the ECMO was started within the 24 and 2 days of onset of hypoxemia or hypercapnia or ARDS patients. So this is the main study in the ECCO. You have the study observationnel, you have the randomized trial, you have some physiological, and with Alain Combe, we summarize this in a table, and all of them use this very early maximum within the 2 days. This is probably the more important things. So the second point is what's the most recent clinical evidence. This is probably one of my favorite study, showing in the sub-analysis what was ancillary study of the ARMA trial, showing in y-axis here the mortality proportion, as you see, and here you have the plateau pressure. These slides should be written from the right to the left, and as you can see, more you decrease the plateau pressure here, more you decrease the mortality. And if you go at the end of this story, no ventilation, no mechanical ventilation, you have zero mortality. This is a concept of the extracorporeal lung support in this case. So the lower the plateau pressure is, the lower the mortality is. So the objective now is to really try to have the minimum value of the alveolar pressure evaluated by the surrogate of plateau pressure, or we have now better evaluation, which is the driving pressure. In this trial published in the New England Journal of Medicine, which it summarized 9 randomized trials on ARDS, we showed in the y-axis here in the mortality, the relative risk of mortality, and this is the driving pressure. With the driving pressure is the plateau pressure minus PEEP. And as you see, more you decrease the driving pressure and more you decrease the mortality. This is exactly in the same way that the plateau pressure. It's the same thing, is a surrogate of the VD. And this large trial performing by Giacomo Bellani, leading by the ECCO2R, as you see, the driving pressure lower than 14 was associated to lower mortality in comparison to patients who have more than 14. And this was confirmed by several other studies more recently. This trial shows the respiratory rate that is a parameter that could be associated to higher mortality. As you see, more you have respiratory rate, more you have open and closed stress in your alveoli. This is open and closed alveoli recruitment, derecruitment, which cause a shear stress and then increase morbidity and mortality in the patient. The second point is the lower pH with higher hypercapnia. This is associated with more mortality in this lung safe study. Then, if you want to summarize the main message of this ancillary study of lung safe study, you have higher PEEP, the lower peak pressure, the lower plateau pressure, the lower driving pressure, the lower respiratory rate, the lower pH, not good. And then all of these parameters you can change and are modifiable to change and to improve the outcome of the patients. So this is associated with improved survival from RDS patients. It's the same for the PCO2. More you increase the PCO2, more you increase the mortality. So all what I present to you is in the way of to decrease the airway pressure and to decrease the PCO2, even you have alveolar hypoventilation. So what are the clinical evidence today to use extracorporeal? This was the first study published by our colleagues Thomas Bean and Arthur Sletsky, showing in just close to 80 patients that you can use the ECCO. That was one safety and feasibility study because it was one of the first. And then you have, unfortunately, as you can see, no significant difference in mortality. This is the tidal volume. You see that the volume decreased to 3 ml per kilogram only at the D1, but after D2, D3, the tidal volume increased up to 6 ml per kilogram in comparison to the control group around 8 ml per kilogram. You see here the difference of the driving pressure. You have lower driving pressure in the first 2 and 3 days, but after the values are the same. Unfortunately, in this trial, there is no significant difference in terms of mortality in this severe hypoxemic RDS patient defined by the PF ratio less than 300, but the others perform an ancillary analysis in the more severe patients, showing that there is difference in the more hypoxemic patients. In this trial, the others suggest that the more hypoxemic patient may benefit. And then now it's not totally true this with the more recent data that you have. As you see, you have only 28 patients, which the sample size is too limited to take any conclusion for these parameters. So now we have several physiological studies, as you see here, showing that we can use the different machines of ECCO, mainly the machines of Baxter. As you see, have the CO2 removal. We show with we can reach 4 milliliters per kilogram without any side effect, which is safe. This was also confirmed by the Supernova study that showed that the use of ECCO to facilitate ultra-protective ventilation is feasible and that a randomized control trial is required. And as presented by my colleague, Dr. Pestana, just previously, the only one big trial is this one, which is neutral, is the REST study coming from UK. As you see in this slide of the Kaplan-Meier curve, the mortality did not change at the primary endpoint, which was the mortality at D19. And as you can see, this study was stopped for futility at half of the inclusion patient at 400 patients. However, this study is very informative for us. Why? Because as you see, the reduction of tidal volume, in fact, the others never reach the 3 milliliters per kilogram. All the patients are above 3 or 4 milliliters per kilogram. This means that the objective was not reached. This is the first probably limitation of the study. And this, as you can see, the low baseline driving pressure and modest reduction in ECCO may be explained by the no significant difference between the driving pressure as shown previously. This may explain also no significant difference. And then in this trial, you have also another parameters with limited is that the others used a low blood flow, not a high blood flow, can limit also the effectiveness and also the membrane is probably not the optimal one. This maybe explain the negative results. More recently, we published this paper last month in the Critical Care journal, and we showed that we can assess the feasibility of the real ultra-low volume ventilation. We try to reach less than 3 ml per kilogram to facilitate it by ECCO in acute respiratory failure. We reported our experience, and we have 45 sessions in 40 patients, and we compared also the machine with low flow, with low extraction of CO2, less than 500 milliliter per minute, and high extraction flow, which is more 1 liter per minute. And then first results are, as you can see here, you have in the left bar the tidal volume in the y-axis, and this is the first 2 days, and you have here at the right, you have the blood rate, the blood flow, and as you can see, we have 40% of the session that we can reach in the blue line, less than 3 ml per kilogram. This was the first paper showing that we can reach 2.1 ml per kilogram in the median value without side effect. And this was mainly possible in this situation with high blood flow, more than 1 liter per minute. The median value was 1.5 liter per minute. And as you can see, the patient who failed was the patient with 0.4 liter per minute, 400 milliliter per minute, with mainly a limited area of the membrane. And then you have a difference in terms also of the driving pressure between the two groups here, and you can see here the difference between both groups. So probably if we want to have a significant difference in the future, we should have a significant difference in terms of driving pressure, in terms of alveolar pressure. We should decrease the VD. And this was not the case in the study of the REST trial. So then using this, you can decrease probably with the ECCO the pressure, and we can have toleration of hypercapnia. This is what I said, the difference between the two strategy of blood flow. If we used less than 5 ml per kilogram, we should probably have a large membrane in the future that the company develops this. And if we use probably a high blood flow, we can consider this as probably something like, as I called, a light ECMO, but not an ECMO, because there's really a low oxygenation effect, even the swing. Just to finish my presentation, I want to present you a clinical case, because in my team, we believe of the prevention of in the more patient at high risk to develop RDS. And then I present you a case of patients of 13 years with a Bayler syndrome, with a problem of the cholangite. And then the patient have received 4 liver transplantation, and we need to make a 5 liver transplantation. This is what we made. We made a double transplantation, as you see, the operating room. We have a liver and kidney transplantation, and the duration was 16 hours here, 6 hours, really long. And as you can see, we are 3 intensivist anesthesiologists here with all the surgeons, 3 teams of surgeons to do this. And then this is a transfusion of during the surgery, 25 red cell blue, 32 frozen frost, and 3 plaquettes, and albumin, and ringer lactate, bicarbonate, etc., etc. Really high flow loading. And then I show you that in this case, we used during the surgery renal replacement therapy, but we also used the extracorporeal support, both for the surgery to make the shunt for the cavus vena, and then we use also this for the protective lung ventilation. And we ventilated the patient during all the surgery with 2 ml per kilogram, with real ultra-protective ventilation. And then this is a screen of the ventilator, as you see, and we maintain this during 1 week after the surgery. And this is the first X-ray the day before surgery, which is can classify it as a normal X-ray. This is just after surgery when the patient go to the ICU, and then is a D3, D5, and then when we remove the ECCO. Then even the patient receives several liters of fluid. As you can see, we avoid an ARDS in this patient because we use 2 milliliters per kilogram tidal volume, which was really a preventive strategy. And then now we can evaluate this. We are now making a study to evaluate this. So my conclusion is CO2 removal, then the ECCO, is really a promising adjuvant therapy strategy for ultra-protective ventilation in probably moderate hypoxemic hypercapnic patient up to 2 or 3 ml per kilogram ideal body weight. Now we can do this with good machines. The potential complications should be taken into account, and they need to be considered, particularly the balance between bleeding and clotting, even on the optimal use of anticoagulation. This is why a high blood flow is probably better to avoid the clotting in these cases. And finally, my feeling, my position is that ECCO could be considered as a pre-ECMO in some selected moderate or mild severe patients, or complementary and not competitive with the ECMO. Then probably ECMO-ECCO could be associated in some cases. Thank you very much for your attention.